welcome to another episode of Question of the Day Board Review. Here is your board question. A 57-year-old male with a history of CKD stage 3 due to long-standing and poorly controlled hypertension and a most recent creatinine clearance of 32 ml per minute presents with headache, confusion, and a left-sided pronator drift. He also had a head CT that showed a left frontal subdural hematoma. Which of the following comorbidities or conditions associated with CKD or chronic kidney disease most significantly contributed to his intracranial hemorrhage? Choice A, antiphospholipid antibodies. Choice B, uremic platelet dysfunction. C, thrombocytopenia. D, factor V Leiden mutation. E, vitamin K deficiency. All right. The answer was B, uremic platelet dysfunction. So we know that uremia causes qualitative defects in platelet function, and the exact etiology of what causes the platelet dysfunction in patients with significantly reduced GFR and creatinine clearance is incompletely understood. There are a couple of reasons that are talked about. Anytime you have 2 to 3 reasons or 2 to 3 possibilities, that means we probably don't have an exact reason as to what the etiology is. At least the commonly accepted etiologies are a reduced activation of the integrin receptors, which are also called the glycoprotein 2B3A receptors. So this is primarily a receptor for fibrinogen, and that activation is supposed to be impaired in patients who have significant uremia. The second postulated mechanism includes platelet granular dysfunction. So basically, it's a storage disorder. It has also been observed in patients with significant uremia. In contrast, what is worth remembering is the von Willebrand's factor in patients with uremia may be close to normal. So it's not necessarily significantly reduced depending on the worsening of kidney function. So when we look at the other choices, antiphospholipid antibody is a prothrombotic state. So that is definitely not the answer for this one. Factor V Leiden mutation, again, causes a hypercoagulable state. You see venous thromboembolisms in these patients rather than hemorrhage. Thrombocytopenia, yes, can be an independent risk factor for bleeding. But in uremia and in kidney dysfunction, it's not the number of platelets that's the problem. It is how the platelets function, which is more of a problem in these patients. When we look at the last choice, which was vitamin K deficiency, typically vitamin K is affected in liver disease, and it affects the production of clotting factors 2, 7, 9, and 10. But no specific mechanism has linked or explained in the setting of uremia. So that's less likely to be the cause in this particular group of patients.